And now I'm delighted to invite Professor Robin Norton. She's the co-founder and principal director of the George Institute for Global Health, a not-for-profit medical research institute with offices in Australia, China, India and the UK, with the aim to facilitate the provision of safe, effective and affordable evidence-based healthcare, especially for disadvantaged population worldwide. In the last decade, it raised $250 million for global health research and currently has projects in no less than 50 countries. Robin is also Executive Director of the George Centre for Healthcare Innovation, Professor of Global Health and James Martin Research Professorial Fellow at the University of Oxford. So a big warm welcome for Professor Robin Norton.
Well, good afternoon. And again, like the others, I appreciate the opportunity to speak with the group today. In particular, I appreciate the opportunity to perhaps build on some of the comments that Lionel made earlier and perhaps bring things slightly away from some of the earlier discussions to focus on frugal innovation. What I'd like to do in my presentation is perhaps talk with you about why the George Institute has focused a lot of its attention on frugal innovation and the rationale for doing so, and then give you some ideas about some of the work that we have been doing to date. But to start off with, from the George Institute's perspective, we see that the world's single greatest health challenge is actually how to provide health care to the 7 billion people on this planet. While most of us in the room will have access to health care, we're aware that 5 billion people do not have reliable access to essential health care. And of that 5 billion people, about half will develop a serious disease before the age of 60. We also know that not only in the UK, but increasingly in low and middle income countries and in Asia, the leading causes of early death and disability are now cardiovascular disease. So if we look at the top 10 conditions of early death and disability in Asia, they're heart disease, stroke, diabetes and kidney disease. And for this reason, the George Institute has focused a lot of its attention on how do we best identify, manage the conditions of cardiovascular disease. So if we look at what is happening globally in terms of the management of cardiovascular disease, particularly in low and middle income countries, I would like over the next few presentations to provide the rationale as to why we think frugal innovation is going to be so important in addressing the growing burden of cardiovascular disease. Some of the earlier work that we undertook in the villages of Andhra Pradesh that Lionel alluded to before focused on looking at individuals at high risk of cardiovascular disease and looking at how they were currently being treated. And what we saw in individuals who had a history of heart attack or individuals with a history of stroke, those individuals who are at greatest risk of cardiovascular disease, only 16% were receiving aspirin, one of the cheapest medications that would be available. Only 9% of those with a history of stroke were receiving aspirin. If we look further at a much larger study, the PURE study that has been undertaken in a range of high-income countries, upper middle, and low-income countries, and again focusing on individuals with coronary heart disease and cerebrovascular disease, we see yet again that the majority of individuals are receiving no drugs for the treatment of those conditions, such that we believe that for most people in the world with serious cardiovascular disease, they receive no treatment whatsoever. if we take a look more broadly at most high-risk people with cardiovascular disease, we see that whereas about 80 million people in the world in high-income countries, there are about 80 million people in high-income countries who are at high risk of cardiovascular disease. By comparison, there are about 250 million people in low and middle income countries who are at high risk of cardiovascular disease. But in contrast, if we look at the spending on cardiovascular and diabetes disease drugs, we see that most of that resource, 100 billion, is spent on that 80 million population in high-income countries, whereas less than 20 billion is spent in low and middle-income countries. If we also look at where are the doctors in the world, and are the doctors available to manage people at high risk of cardiovascular disease? If we look at the rate of doctors per 10,000 population, in the UK, the US, there's about 27 to 30 doctors per 10,000 population. In China and South America, about 14 per 10,000. In India, about 6 per 10,000. In sub-Saharan Africa and parts of Southeast Asia, it's down to 1 per 10,000 people. So you can see that what we have is a vast unmet need in terms of the treatment of cardiovascular disease in the 21st century within the world. There is an inadequate workforce to be able to manage those conditions and inadequate resources to manage those conditions. We also see, and I'm not presenting that data here, great variation in the quality of care that's provided to those people who receive care. And basically, the cost of medical care is very high relative to the ability of those individuals to pay. So the challenge that we have at the moment is every decade, many tens of millions of people die prematurely and unnecessarily from preventable cardiovascular disease. We do know how to treat it. People are just not being treated at the moment. So coming back to my initial premise is we need to find ways to be able to provide health care for the 5 billion people who do not have it at the moment. To continue as we're doing at the moment is not going to make a huge difference in our lifetimes. Radical change is needed. Incremental change will not be enough. And to use an Indian term, the world needs jugaad innovation or frugal innovation if we're going to produce dramatic changes to the current situation. This requires innovation in terms of healthcare services, technology and financing. It means we must have innovation that focuses, that is accessible to the bottom 3 billion who are living on less than $250 a day. It means that we've got to think about a fundamental change in the way that we market price technologies, for example. We need to move from high margin, low volume to a low margin, high volume approach to the provision of technology. And we know it's possible in other areas beyond the cardiovascular disease. Our colleague earlier presentation touched on some of the work in the prosthetic area, and we know from India that it is possible to produce prostheses that are affordable in these countries, prostheses that are also relevant to the populations, the people in those countries. As we see here, without our design, people can kneel, squat and climb trees, which isn't possible with other designs. So there is a need for innovation that is cheap and innovation that focuses on the needs of people in those low and middle income countries. We also see another wonderful example from India, the Aravind Eye Hospitals, with technical innovation that focused on an intraocular lens for 10% of the market price. The Aravind Eye Hospitals took this technological innovation, and then looked at service innovation, where they were able to reduce, with increasing the number of nurses to the number of surgeons, increasing operating tables, instrument sets, they were able to do 6 to 8 operations per hour, but importantly also showed that they were able to keep the complication rates low, the infection rates low, and with low rates of corrective surgery. So we know it is possible to be innovative. So with cardiovascular disease, given it is the leading cause of death in many of these countries now, where do we start? It does mean with a lack of doctors, we need to re-engineer the workforce. We need more people in the workforce, the healthcare workforce, who are less expensive. We need to ensure there is less variation in quality. And if we're going to do that, then that requires us to develop low-cost technologies, electronic decision supports, and point-of-care diagnostics that will allow us to do this. I might just add another focus that I'm not going to speak about today, but one that the George has been involved in, is also the development of low-cost drugs, fixed-dose, once-a-day polypill combinations. And we're also working on implantable drug-device combinations that can be used in these settings. But to move to look at re-engineering the workforce, as I said, we need a larger, less expensive, more reliable workforce. A primary care workforce model that we use in high-income countries like the UK is not going to work in these settings. We cannot focus on physicians. There's just not we cannot train up enough physicians within places like India within the time that's required. Indeed, if we were to have the same number of doctors in India as we do in the UK per head of population, we'd need to move from 500,000 doctors as there are currently to 3 million. As you can see, that's just not feasible in a short period of time. So what we've been doing, and as Lionel referred to before, we have been working with village healthcare workers, the ASHES, the young women who have initially been trained to work with maternal and child health settings, but we're saying, can we train those workers to also focus on cardiovascular disease? These are government-funded community healthcare workers who cost 70% less than physicians, and we have developed algorithms of care for screening and treatment of individuals at high risk. What we've found from the initial work that we've done, using these standardised algorithms, these community health workers have been able to better identify individuals at high risk of cardiovascular disease compared with physicians. We've also been able to show that the agreement between these healthcare workers and physicians regarding the treatment of these individuals is almost 100%. The next phase of this project, where we're starting to work with Lionel and the team at the Institute of Biomedical Engineering, is ensuring that we move to that the quality of care is consistent and the variations of care that are provided by these health care workers are minimised. So we're focusing first on clinical decision support systems, systematic medical appraisal, referral and treatment systems, smart health as we've referred to. These are clinical applications that are going to target the top 10 causes of premature death and disability in these communities, as well as providing operational applications for clinic management, supply chain and training. We also hope to move to look at provider and consumer applications, all using a secure cloud-based system. Again, with Lionel and the team at the Institute of Biomedical Engineering, we're also looking at how do we incorporate smart sensors, remote electronic sensors for use in mobile phones, lab-on-chip blood pressure, ECG, heart sounds, oximetry, fetal heart rate, spirometry, echocardiography. There really is hopefully no limit to the sorts of things that we can utilise as point-of-care diagnostics. But we're also, as I mentioned before, moving to look at applications for consumers, personal risk monitoring, early warning signs and symptoms, medication adherence prompts, smoking cessation tools, weight loss and food choice tools, data upload and appointment scheduling. And as Lionel indicated before, mobile phone use in these environments are increasing dramatically. The costs are coming down, so there is real potential that we can use these low-cost technologies in these environments. So essentially what we're aiming to do in this environment in Andhra Pradesh, but really, and also starting to work in China and elsewhere, is looking at the concept of a village-based healthcare ecosystem that utilises digital health technologies, training community healthcare workers who have regional medical supervision, smartphone-guided personalised care, wireless point-of-care diagnostics, evidence-based algorithms, both clinical and operation, ensuring continuous quality control. So, to summarise and to finish, I'd really like to put a challenge out to many of you in the audience. I appreciate, of course, the importance of technology at that high end. We must have that. But we also need to encourage a cadre of engineers to really start working with us on healthcare for developing countries. That Jugaad innovation, the Frugal innovation that will improve healthcare, innovative low-cost technologies, and again, reiterating some of the comments that others have made before, that's going to require this cross-disciplinary scientific partnerships that many of you have referred to. We need to engage with social impact and investment sector. I think there's an increasing interest from the social impact investment sector who are interested not only in financial returns but social returns, so that we can then move to implementation and scale up and sustainability of these approaches. Thank you.